Okay, my name's Julia Dix. I work as a breast surgeon at Barnsley Hospital. I've been there 6 years now, so hopefully my name's familiar to you. I just have to thank Miss Wav, who's donated a lot of the slides for me today. Okay. So, per 500 population, probably generates about 400 secondary clinic referrals a year. We see about 50 new patient referrals each week, and that generates in Barnsley about 200 breast cancers a year. A third of those do come through the screening programme, and the rest will present to us symptomatically. About 9 out of 10 of our new patient referrals are non-malignant, and we discharge about 70% of patients from our one-stop clinic on their first appointment. So in primary care, most people will see on average 2 breast consultations per month. I suspect it's probably skewed a little bit more towards the female GPs in some practices where that's available, and that will be for a range of different symptoms. About 40% will be for a breast lump, and about 60% of those will get referred through to clinic. 40% breast pain, it's quite a common symptom, and we'll be covering that later. And a percentage of those will get referred. Nipple discharge, a relatively high percentage of those will get referred through, and again that's something that we'll be covering later on in the talk. And then there's various other symptoms, and obviously the referral rates for those can be variable. So breast lumps, as I've mentioned already, about 10 to 1 of those will 10 benign for every malignant lump that we get through. There's lots of other different reasons for lumps. Probably out of the lumps that are seen in primary care, some of those may not get referred through, so maybe it's as many as 20 to 1 of the lumps that are seen in primary care actually are malignant lumps. So it's a question of how to filter those. Something like that's fairly straightforward, isn't it? So just a case just to go through. So if you have a 32-year-old lady who's complaining of a tender lump in the right breast for about a 3-week period, she has got a family history. Her sister was diagnosed at the age of 32. So obviously that's going to be, in her mind, on examination, the right breast slightly more nodular than the left, but no particular lumps actually felt. She's mid-cycle. Perhaps we could just have a show of hands. What would you do? So option 1 would be to reassess in 2 weeks, or you could alternatively refer her straight through in view of her family history to breast clinic. So who would see again in 2 weeks? And those of you that would refer through? I think there's a lot of people abstaining here. Okay. That's fine. I think if you can't feel a lump, I think either of those is probably reasonable. I do tend to, if patients can feel lumps, I'd probably lean more towards just referring. And with her family history, she's going to end up being seen at some point. So it's a question of whether that's in the symptomatic clinic or the family history clinic. Oh, I've got that on the slide. So, referring through to breast clinic, obviously she's had a clinical assessment there and an ultrasound. The ultrasound shows a 2 centimetre mass, thought to be benign, and a biopsy is taken. That biopsy shows normal breast tissue. So, again, do we think we'll just say, is that an acceptable result, or do we need further investigations? Who thinks that would be okay to discharge? And who would think we need to do something further? Lots of abstaining again. Okay. So that's a non-concordant result. There's a lump that's been seen, and so if it's just showing normal breast tissue, then we would need to do something further. So this patient would require a repeat biopsy to confirm the diagnosis of, in this case, a fibroadenoma. Can we just again have a show of hands? What do you think we should be doing now? Reassure and discharge. consider referral through to the family history clinic or excision of the lump. Okay, number 1. Number 2. Number 3. Okay, so I think probably number 2 was the most popular option. We don't, and I think that's correct. We don't often take lumps out nowadays. I think 10, 15 years ago, if somebody had a lump, they'd be put on a list to be taken out. But nowadays, we tend to remove fibroadenomas if they're symptomatic, if they're growing. But otherwise, or if the histology shows a query phylloidy, something like that. But generally, we don't tend to take the lumps out. But obviously, she's got a first-degree relative who was under the age of 40 when she was diagnosed with her breast cancer, so she does need a referral through to the family history clinic. And obviously, the next session goes into family history in a bit more detail. So characteristics of malignant lump, this is again very clear, isn't it? It's something that's ulcerating, it's distorting the breast. You can see that it's eroding into the skin, so that's a fairly clearly malignant lump, but it's not always so obvious. The features, as you see on the left there, are hard lump, but lobular cancers, which account for about 15% of breast cancers, often don't feel hard. They can more often present with some distortion, a dimple, something like that. So they can be a more diffuse change. Irregular margins, that's the most common presentation, but occasionally, particularly in younger women with high-grade cancers, they can feel quite rounded, have a more pushing edge and feel quite smooth. Skin tethering or fixation associated with lump is, again, if it's present, is going to raise those alarm bells. Axillary swelling, again, it's not a common presentation. Even those ladies that do turn out to have lymph nodes involved, they may not be particularly enlarged or palpable, particularly in a larger lady. Older age. The majority of breast cancers are in older women, but we do see them in women in their 30s, sometimes in their 20s, very occasionally younger than that. It's highly unusual, but you just need to keep that in mind for all ladies with a breast lump. So lots and lots of different reasons why women might have lumps. We've mentioned before, there's lots of benign reasons as well. Can simply be just benign breast change, fibroadenomas, particularly in the younger group, cysts in women in their 40s, in particularly that sort of perimenopausal group. Sometimes it can be things like skin cysts, sebaceous cysts, or dermal cysts that are on the breast area. Ductal papillomas don't often present clinically with a lump, but can present in other ways, and we'll go through that later. Fat necrosis and hematomas can appear worrying when they're seen, and obviously need investigating, but can be quite clear on imaging as to what's going on there. Mastitis and abscesses, again, we'll talk through in a bit more detail later on about in breast sepsis, which can be quite troublesome and require quite a lot of input, so we'll talk through those. Cancers, sarcomas, lymphomas, metastases rarely, and implant-related lumps, I think we're seeing, probably most people are seeing more frequently now. So what do we do? Well, when they come to us, obviously clinical assessment. If there's a lump present, they'll go for imaging. The over 40s will have a mammogram, and if there's something there or something on clinical examination, an ultrasound and biopsy. Those women between 25 and 40, ultrasound and biopsy. And the younger end of things may not require a biopsy, may require just an ultrasound or just a biopsy, one or the other. It's okay. So we'll start with fibroadenomas. These generally do present in that younger age group, often 25 to 30, sometimes even younger. We get some late teenage girls come through sometimes with these kind of lumps. They do tend to feel quite characteristically smooth, quite mobile. That name breast mouse is there for a reason. Generally, they're between 1 and 3 centimetres. Over about 3 centimetres, we tend to offer an excision. Occasionally, we get large ones come through. I think the largest I've taken out was about 15 centimetres. And those, obviously, they do need removing. Phylloides tumours can present as well. We had a lady in her 20s who presented with what was thought to be a fibroadenoma, but was then proved to be a malignant phylloides. That was about 5 centimetres. So as I say, the smaller ones that come through, they're commonly 2 centimetres if they're asymptomatic, and particularly in the younger group, would generally just leave alone. If they're over 25, they will have a biopsy just to confirm the diagnosis, and as long as that's all concordant, then we wouldn't do anything further. We'd just ask ladies to keep an eye on it. If they notice that they thought it was changing, or if they do find sometimes if it sits on the bra line, something like that, it might be annoying. So occasionally, you refer for excision in that case. So that would there's a picture there just of a giant fibroadenoma. So that's not a malignant lesion, but just a very large fibroadenoma. Cysts are associated with involutionary change, so often again in the 35 to 55, that perimenopausal group. They can be quite variable in presentation. Generally, women are tending to come with a tender lump. Sometimes they can come up quite quickly. People that quite regularly examine themselves will say, I'm sure it wasn't there, and then all of a sudden, occasionally they can even be sort of quite visible if they're quite superficial. And sometimes bilateral. They can be quite obvious on examination, but if they're in a denser area of breast tissue, sometimes they can feel quite firm or hard, and it can be they can sort of be clinically more indeterminate. We aspirate symptomatic cysts, so if there's something palpable there, then our policy would be to aspirate that. We don't send it for cytology unless it's blood stained, or if it's a recurrently filling up cyst. Generally they will settle down with time. Some women it's a one-off event. Sometimes some women end up coming back to us on a 6-monthly or yearly basis because they end up with recurrent cysts, and it can be quite troublesome, but we just tend to aspirate them as they occur, and just reassure them that they will settle down. Though obviously if they do notice any new lumps, even if they've had cysts in the past and they just think it's another one of their cysts, then they do need to come and get things checked and confirm that that's all it is. Benign breast change, common particularly in the younger end of things, so it can happen at any point, whilst a woman's menstruating, but it tends to be the younger end of things where people present with quite, cyclical. It tends to be cyclical change, and it can be quite prominent at times, and feel quite significant, but generally will then settle with the cycle. Often going to be tender and painful as well. The hormonal change tends to feel slightly more diffuse and a little more rubbery, and obviously when that diagnosis is confirmed, it's mainly about reassurance, breast pain management, and continuing breast self-awareness. Implant problems. We get more and more ladies coming through with implants. There was obviously a few years ago with the PIP crisis, we had a lot of referrals through at that time. That's mostly waned now. Capsule formation can occur to anybody that's had implants in, and that will make the implants feel harder, uncomfortable, a bit more prominent, more visible. Incidence of rupture is probably about 2 or 3% a year, so the longer somebody's had implants in, the more likely that is. It's quite unusual to happen in the first sort of 5 years, but over time, and often will present with perhaps a change in shape or contour of the breast, sometimes with lumps which are then silicon granulomas, which would be confirmed on imaging. They can shift, so sometimes people can feel their implants become more palpable, often at the lateral edge, so they're sort of feeling lumps at the edge of their breast, which is actually where the implant has shifted over. And obviously as women get older, particularly if they've had them put in young and then have kids, then their body's shape changes, and therefore the implant changes, and they can notice more of a difference in those cases as well. I'm sure everybody's seen episodes of breast sepsis. It can be quite difficult to manage sometimes, certainly the cases that we get through. fairly obvious presentations, red, tender, swollen areas. Can be associated with generalised symptoms, fever and flu-like symptoms, particularly in lactational women, but can occur with a non-lactational as well. Generally, if will respond pretty well to antibiotics, 48 hours, and the patients will be feeling a lot better. But sometimes can progress to abscess formation and be more troublesome. So in that lactational group, the younger group, those abscesses or mastitis areas that are occurring at the periphery of the breast, generally going to be Staph aureus. Not always associated with pregnancy and lactational changes, but generally would be. Obviously worth just checking for diabetes if it's not in that situation. Flucloxacillin would be the antibiotic of choice there, and if abscesses do present, then we would manage those with serial aspirations. So that would just be either clinically or under ultrasound, just aspirating the abscess repeatedly until it settles down. Try to avoid incising and draining in a woman who's breastfeeding in particular because of the risk of fistulation. The other group that you tend to see it in is this, the older age group with the periareola. That's strongly associated with smoking, and one of the first things we tend to do is try to get them to stop smoking. It's a slightly different organism generally that's involved there, and it's worth just using something that's going to cover the anaerobes as well with a coamoxiclav. But again, the same sort of serial aspiration. I think they've probably got a slightly higher chance of them moving on to incision and drainage. And those are the group that sometimes end up going down the line of total duct excisions. So lactational, some women just seem to just be prone to mastitis, whether it's associated with cracked nipples or breastfeeding technique. We would advise people to continue breastfeeding because that will then empty the breast rather than stopping breastfeeding and getting that engorgement, and then the bacteria are just going to proliferate. So there's no need, to stop feeding. They can continue feeding as long as it's not contraindicated by antibiotic therapy. As mentioned before, it's a high risk of lactational fistulation, and most of these will settle with aspiration, so it's not normally a problem. Obviously, if the patient does end up going to theatre, then at that point you would advise them to stop breastfeeding. So non-lactational, so mammary duct associated inflammatory disease would be associated with duct ectasia and that periductal mastitis, as I said, strongly associated with smoking, and we would avoid operating on, apart from in the acute setting for drainage of an abscess, we'd avoid operating on these women until they'd stop smoking because of the risk of recurrent sepsis. So indications for surgery, if repeated aspirations fail, obviously, if there's a situation like this where, that's virtually discharging itself anyway, so probably doesn't even need to go to theatre. Sometimes when an ultrasound's performed, an attempted aspiration may fail, or if the radiologist tells us that it's all just very multiloculated, then that's the situation one would just take the lady to theatre. But obviously then you're leaving them with wounds needing to be packed for a 4 to 6 week period till things heal up. So duct ectasia and periductal mastitis, probably 75% of women may have this and be completely asymptomatic from it. For those that do have symptoms, they can present with nipple discharge, occasionally bloody nipple discharge, or nipple inversion. The nipple inversion tends to be quite slit-like. It looks like there's a little crease in the nipple, rather than a sort of generalised pulling in, but like a little line, and that's typical for duct ectasia, and appears quite benign when we see it. So periductal mastitis can occur in 6% of patients, presenting with pain, sometimes with infections and abscesses, as we've mentioned before, or again with the nipple inversion. And a percentage of patients will get breast abscesses, and these are the group that are quite difficult to treat. often getting recurring, over years, episodes. They're coming for antibiotics, coming in intermittently for abscesses to be drained. So for those ladies that do have a chronic periductal mastitis, we'd tend to end up with at the point of surgery for those. So we'd do a total duct excision. So generally a periareolar incision, taking the ducts all the way from behind the nipple. Generally works quite well, but there is a risk of nipple necrosis, nipple numbness, and recurrent sepsis. So again, we would, I would always ask ladies to stop smoking before going down that line. Otherwise, you've got quite a significant chance of wound breakdown, and then you're back at square one packing wounds. Those patients that present with fistulas, so sometimes these are women that have had abscesses incised and drained, or possibly even had a total duct excision, then developed a fistula, and they'll tend to describe a build-up in the breast and then a discharge through the same point, or sometimes they're just a constant spotting from a point from a fistula on the areola or the areolar margin, and those don't settle down. There's a fistula formed there, and at some point they're going to come to surgery. Again, preferably having stopped smoking first. Inflammatory breast cancer is unusual, but obviously if you have a mastitis that isn't settling down, it can happen in any age group, inflammatory breast cancer, and it does look as if there must be infection going on there. It's red, it's hard, it can feel hot, it can be tender, you can have that swollen look, but it doesn't respond to antibiotics, and obviously needs referral for imaging and biopsy. Rarities, TB. I think I've seen one, so it's not common. That particular lady was known to have TB, and that's often the case. They'll have symptoms elsewhere, and generally it's a case of managing the TB, treating the TB, rather than needing anything specific doing. But occasionally surgical debridement if that's the presentation. Granulomatous mastitis, again, another presentation of mastitis, can be more florid and again not settling. So again, that's a histological diagnosis and then would be treated with steroids. So another case study, we're looking at nipple discharge now, something we see quite a lot of. So this is an older lady, 61 years of age, 4-month history of unilateral, spontaneous, brown and red nipple discharge, no other breast symptoms, no lumps on examination. She's finding it a bit embarrassing. She's worried about people noticing the discharge, particularly when she's swimming. Examination normal, but when she squeezes, you can see that there is a small little bleb of brown discharge in the left nipple. So what would you do now? I'm guessing, would you observe or would you refer this lady through? Who would refer? Pretty much everybody. Okay. Yeah, absolutely. So she's come through for her imaging, been seen in clinic, similar results. Imaging's been performed, mammogram and ultrasound, both normal. There we go. So at her age, with new discharge, imaging's normal, the choices would be to offer her a surgical microdocectomy or total duct excision, or to watch and wait and see her again in 3 months' time, see if this is a persistent problem. It's been going on 4 months already, so I think we would lean towards surgery, but obviously that's something to be discussed with the patient. This lady's chosen to be watched, so she's come back again 3 months later. Now at this point there is a bit of thickening within the breast, and core biopsy does confirm a B4, which is suspicious for malignancy. So at this point she has an excision, a microdocectomy, and that does confirm DCIS, which is tracking towards the nipple. At that size of DCIS, we would generally be looking at a mastectomy. So nipple discharge comes in various forms, and as you look across the slide from left to right, probably in increasing rarity of symptoms, and also slightly more worrying symptoms each time. So a lady who comes and says when she squeezes her nipple she can get a bit of creamy yellowish discharge out, that's nothing, that would just be a case of reassuring her that's quite normal. A lady who comes who's having spontaneous milky discharge, more significant, then it would be worth looking into that a bit more, see if there's any hormonal reason for it. So checking prolactin levels, obviously a pregnancy test if that's relevant. Bloody discharge can occur in pregnancy, but does need monitoring to make sure that that does settle down. Ductectasia discharge, greenish, but I think this was one of the quiz questions, so if you've still got your sheets you can check. So greenish, brownish, multi-duct, so often bilateral, and it can look quite unpleasant, but sometimes people think it's a bit purulent or greenish. If it's a creamy greenish sort of colour, sometimes people think it's a pussy discharge, something like that. It often comes from 2 or 3 points on the nipple when you're examining. Nothing particular to be done for that, unless it's very profuse and the patient's finding it quite troublesome, in which case it would be looking at a total duct excision. Papillomas clinically, classically do present with a clear, quite profuse discharge, so it's quite watery. The patient may notice that marking through onto their clothes, not just a little thick sort of smudge, but actually quite a watery area that sort of marks onto a circle on their clothes, or sometimes can be a bloody discharge as well. Obviously, that needs more investigations. Papillomas often do show up on imaging, and if diagnosed, you'd then be looking at a microdocectomy, so you're looking to take that particular duct away. Again, DCIS can present with a clear or a bloody discharge. Sometimes that blood, if it's old blood, it can be a more brownish colour or a bright red, though it's difficult sometimes to tell whether it's that brownish ductectasia discharge or if it is that old blood brownish discharge. So imaging in that case, and if it's a persistent discharge that you think maybe it is bloody, then surgery. So blood-stained, as said, often it can be the ductectasia that's the cause. That's the most common cause. Occasionally papillomas, and rarely DCIS. Sometimes bright red blood can be bilateral in pregnancy, and due to the epithelial hyperplasia, basically, that occurs, hormonal changes throughout the body. So again, those sorts of changes in the ducts, but that obviously does need monitoring, and if it persists beyond pregnancy and lactation, then you'd be looking at diagnostic investigations. Often imaging is normal, or sometimes can confirm papillomas or ductectasia. We don't tend to do cytology. It's not helpful. So it's imaging, or then if there's nothing further diagnosed and it persists, then we'll be looking at surgery. So this more worrying group, this single duct spontaneous, non-bloody, often ductectasia or papilloma. DCIS, often there will be some calcifications visible, but sometimes that's not the case, but we'd then be following those ladies up and offering surgery. Paget's disease, we get quite a bit of skin changes referred through. Paget's disease is always on the areola area rather than elsewhere on the breast. It's where the ducts are coming through, so either the nipple or areola area, and typically if it's extensive, then you're going to get erosion of the nipple. So that's quite classical when it presents like that. But generally when we see something like this, we'll be doing a punch biopsy to confirm the diagnosis. Papillomas, as I've said, on an ultrasound, generally they can see they're very clever. They can see the little papillomas sitting in a duct, and those would be biopsied. They are benign, but they generally do get excised to exclude papillary carcinoma in situ or DCIS, low-grade DCIS. Multiple papillomas within the breast are associated with increased breast cancer risk in the long term, but it's quite rare. Okay, another case study, in case you'd fallen asleep. I'm sure everybody's seen a lady like this. 31, 2 months history of severe pain in her breasts, worse on the right than the left. Her breast is very lumpy. She's not confident at examining herself. She's not sure whether she can feel anything or not. And she's finding her pain means that she doesn't want to hug anybody. It's interfering with her life. On examination, she's a large lady, generally lumpy breast, generally tender. She's not on any tablets. Okay, so what would we be looking to do with this lady? Any thoughts? Nobody's going to talk to me. You're all very shy. Do they? Okay. No? So, breast pain is very common, particularly in that premenopausal group. A majority of it is cyclical and hormonal in nature. Some of it's going to be non-cyclical. Again, quite often that will be musculoskeletal in nature. And some of it doesn't seem to necessarily fit into any particular pattern. Postmenopausal is obviously not going to necessarily, be hormonal in nature unless the patient's on HRT, but it can be musculoskeletal. I had a lady in clinic a few weeks ago who had a cabbage, so she'd got some breast pain. I don't think that's sternotomy. That's probably going to give you a bit of pain, isn't it? Patients often have been doing a lot of DIY or gardening. So the cyclical breast pain group, which is the majority of what we see, very common, can be associated with some swelling or these areas of tenderness within the breast that feel a bit thicker, those sorts of changes. Classically, it would occur prior to menstruation and then settle again afterwards. Most commonly, it's mild. I think a lot of women suffer from some breast pain, and just manage it themselves. And it can sometimes seem to be worse at a certain point in a lady's life and then settle down again. Nobody really knows quite why it happens, to be honest. You can take biopsies at certain points when it's painful and not painful. You're not going to see any difference. So there's not a particular reason why it happens. It's just something that seems to occur. It can be helpful to look at a diary, see whether you can establish any kind of pattern, and also look at severity. So sometimes women aren't necessarily aware of quite where it's fitting in with their cycle, but if you ask them to keep a diary, keep a record of what's going on, then you can confirm that it is more that cyclical pattern, and be more confident about reassuring the patient. So the main management is reassuring that it's not worrying in nature, that this is quite a common thing. We tend to look at simple painkillers. I sometimes suggest using non-steroidals topically, particularly if some ladies sort of have a particular area that seems to be tender, then sometimes that can help. Diet, I think, was this one of the questions as well? Yes, so here are your answers. Low-fat diet, and avoiding things like tea, coffee and chocolate. And some women will respond very well to that. Other women, of course, around the time of their period are eating more chocolate. So, bras. Most women don't wear bras that fit. Sometimes it's I think it's part of the examination is to look at them in their bra as well, and sometimes it's very obvious that the bra is fitting very badly, and even if you think it may be okay, or you're not confident about looking at that kind of thing, it's worth just suggesting that they go to get their bras fitted again. They may have lost weight. If they've got bras that are old, they won't be supporting them very well. I often suggest as well trying to avoid bras with wires, because often it's that lateral part of the breast that's tender, and wires just press in that area and don't let things settle down. I don't recommend evening primrose oil. Some women swear by it, and that's fine, but it's not something that I would tend to recommend. So for the group that come through to us, majority of them we do reassure, but for those that do have very bad cyclical pain, then we then look at things like danazol, bromocriptine or tamoxifen, even surgery at the end. I've only seen one lady ever who's come to surgery for breast pain, but it does happen, rarely. Most women, when you start to talk to them about these hormonal type treatments, actually don't want to go down that line. They don't want to accept the side effects that go with that. But for some women, it can be a lifeline. If focally tender, then we would assess with imaging. So those are the group that would perhaps come through to us, and sometimes it can be, a deep-seated cyst or something like that. Very occasionally it's associated with a breast cancer. I think most people who've been doing breast imaging for a while would say, yes, there was this lady who came and she pointed, it was sore here, imaged her, and there was a small cancer there. It's anecdotal. It's if you image enough women over 40, you're going to pick up some breast cancers. But it's for patients, I think, a focal breast pain can be something that they do worry about, and they do want checking out. But I think a lot of it is probably musculoskeletal. And there's another quiz answer there. I don't think you collected the sheets, did you? That was a mistake. Okay. So I think, as we've discussed right at the beginning, most of you are only seeing sort of 1 or 2 breast ladies a month. So I think if there's doubts, then, the sensible thing is just to get them referred up. All breast referrals are seen within 2 weeks, whether they're 2-week weight referrals or just pure symptomatic referrals. So you don't need to worry too much which forms you put them on, because we see everybody within 2 weeks. They're all seen within our one-stop clinic where we have access to imaging. So imaging and biopsies all occur on that first visit as required. We do also have a separate family history clinic, so if a patient has no symptoms but is concerned about their family history, then there is that separate clinic. But that's not within 2 weeks, that's just a general clinic. So it's for those separate group that are just concerned about their family history, not those with symptoms. So those with symptoms, as I say, all seen within 2 weeks. And that's me done. Any questions?
I had a patient a while back who was living in Spain half the year. She travels between Spain and England, and she came with a report. I didn't understand all the details in the report, but basically I think it was some sort of fibrocystic disease. So she had multiple cysts, and they gave it a stage, and I can't remember if it was stage 3 or something like that. And they said she just basically needs annual follow-up. So I've never heard of the staging. It seemed like, I think it was a fibrocystic kind of disease, or cystic disease, I don't know. But I've never seen it in any reports from England, so I just wondered if you'd heard of it.
No, that's not a normal thing to stage, fibrocystic disease, or indeed we wouldn't follow it up either, so I'm confused, I don't know.
Okay.
Anyone else? Which topical non-steroidal anti-inflammatory do you find is more helpful?
I normally just look at ibuprofen, something simple to start with.
Any other questions? Do you know, I think they've had a holiday, you see, a whole month, and that's why you watch later on they'll all start waking up and another one. You're gonna...
One of those clinical cases you mentioned, it took more than 3 months to reach a diagnosis, I think, didn't you? Do you anticipate any problems now that the government's talking about new targets for time to diagnosis for cancers across all specialties? Because I mean, we know that it's not always easy to reach a firm diagnosis straight away.
I think that case is quite an unusual case. In the majority of our cases, they come 90% with a lump. We see them and diagnose them within 2 days normally, so we see them again back in our clinic on the Thursday. I think, in that case, we were looking at surgery initially, and that's something that's a hypothetical case that is discussed. Not everybody's going to be within that time frame, as you say, but I think on the whole, our patients we don't reach on any of our targets presently. So I think we're lucky in the way that we run with our imaging and biopsies all done in that first one-stop clinic. We're probably more set up than a lot of other areas to achieve those targets. I think it's harder when you've got to do things like endoscopies or CTs and you're relying on other departments to help with that. But for us, I think we're kind of there already for the majority of patients.
Okay.
Any other questions? I see. Told you. Got 2 more now.
What do you think about some of the recent controversies about breast?
About breast, sorry?
Breast screening.
Breast.
The question again.
I think, there was a lot of negative press about over-treatment, and sometimes, when particularly when things come through and it's indeterminate on biopsies, and patients can end up having repeat biopsies or open surgery, there are cases that you kind of think, well, maybe this hasn't done them any favours, but the latest evidence coming out, I think, does on balance support a survival benefit for breast screening, and I think we should be recommending women attending for breast screening. It's really difficult when you look at the statistics. It depends how you look at it, which group you look at, and how you measure your benefits and your survivals, and where you think those groups should have been in the end. I've seen some really good presentations on that subject, but I think on balance, it does save lives.
Okay, sorry. One more.
It's really a carry on from that question, because I was interested in that. Do you think that extending the current screening and lowering the age group, say, to 45 and extending to the sort of late 70s is justified at the moment?
Well, I mean, as I'm sure you're aware, the extension to 47 is already being rolled out, though currently still on a trial basis. The main benefit of that means that you are catching women before they're 50, because the current system of 49 to 52 means that some women are not coming till they're 51, whereas rolling it down does mean that you are catching everybody before they're 50, and I think that's valuable. In the older end, obviously it's being extended up to 73. I do think probably keeping it as patients self-referring after that point is probably sensible. Just because of comorbidities coming in and things like that, obviously, screening is really for your well population, and if patients are likely to be diagnosed with something that may not present during their lifetime, you're not really doing them any favours. But of course, patients don't necessarily see it like that, and it's not always the fittest ladies that we see come.
Any last questions? Go on.
You're diagnosed with breast cancer when you're younger, and you've had some observations. Do you screen for uterine or ovarian cancers?
Not routinely. So obviously, if they are younger, if there's any characteristics that make you think of a genetic type, then those patients may well be referred through to the geneticists. But unless they're kind of amongst that BRCA type group, then we wouldn't be looking for ovarian.
I had a patient who was diagnosed with breast cancer at the age of 55, who had 2 maternal aunts who had breast cancer, and she was told that her cancer was, I think it was triple negative, and she was told that was usually associated with the genetic kind but was seen in younger women. And she wanted to know about how, in terms of the rest of her family, her daughter, her sister, if they would need screening.
I think we've got the next one's all over that bit, so probably that's all tied in with that.
And then Dr. Julie was an answer all the questions we've just Okay, so shall we end there? And as I say, later on there'll be more questions. Thank you very much.